Welcome back to the Full Code Podcast Critical Minutes series. This is where we do more of our short form content and try to answer some burning questions. So today's topic that I wanted to get into was albumin, and more specifically, why albumin is bullshit. First, let's talk about what albumin is. Albumin is the most abundant plasma protein circulating in your body. Where does it come from? The liver. If you have a healthy, functioning liver, then your hepatocytes are going to produce albumin, and that will be sent out into your systemic circulation to help with transport of things like endogenous molecules, drugs. So any medication that's highly protein bound. So in instances where you have low serum albumin, that's why you have an increased risk for things like drug toxicity, because you have circulating drugs that have nothing to attach to. Why is albumin so important? Traditionally, you're going to learn about things like oncotic pressure and hydrostatic pressure. And historically, you learn that those are the two oppositional forces that maintain your intravascular volume. So how does that apply to us in the ICU? We often see patients that have things like liver disease, or they have an ongoing process or a concomitant process.
Bro, what are you talking about, man?
Like sepsis or say trauma. Now, in addition to this, we understand that there's something called an endothelial glycocalyx. This is just a layer, a gel layer within your vessels that also assists in this process. We won't get down into that right now. That'll be for a later episode. Right now, we mainly want to talk about albumin, more specifically, when we're giving it, why we're giving it, and when it's appropriate or inappropriate to give. Now, the first thing to demystify is you see the bottle of albumin. What does the 5% or the 25% or the 5 grams or the 25 grams mean? 5% is going to be more iso-oncotic. Now, remember, we talked about that before. Oncotic pressure. What is oncotic pressure? Now, before we get too far down the line, let's roll this back a little bit and talk a little bit more about oncotic pressure. In school, you probably learned about things like osmolarity, osmolality. You may remember oncotic pressure or hydrostatic pressure. Boring. Earlier, we mentioned that hydrostatic pressure and oncotic pressure both play a delicate balance in relationship and in conjunction with the endothelial glycocalyx. Oncotic pressure is the portion of osmotic pressure that is governed by these large molecules. And when we say large molecules, what we mean primarily are proteins. Specifically, in this case, we're talking about albumin. Now, the short version of the story is hydrostatic pressure wants to push fluid out. Oncotic pressure wants to bring fluid in. Oncotic pressure, because it's made up by these large particles, are unable to pass through the capillary wall and thus act as a form of an anchor for that volume within inside that space. In cases where you have low serum albumin, you can become somewhat leaky. That situation can be exacerbated by acute physiologic stress or disease processes. A great example of this can be seen in sepsis. While in sepsis, there's obviously a vasodilatory component, but in addition to this, there is the inflammatory component and the damage that occurs to your vessels, specifically that endothelial glycocalyx. Factors like TNF-alpha or interleukins can cause enzymatic shedding of that endothelial layer and allow for albumin to escape once that layer is damaged. As you can already see, once disease processes start to build up, things can spiral out of control very quickly. Now that we've talked about what it is, let's talk about when we use it and, more importantly, when we shouldn't use it. To answer that question, let's first ask ourselves another question. When are we typically using it? When have you seen it used in practice? I would say that by and large, most of you, when you've seen albumin used, it's usually in the setting of hypotension. Now, the context of that hypotension matters a lot, right?
Stop it. Get some help.
It's very likely that most of you have seen albumin used in the setting of a patient that's on dialysis. They often have PRN orders for albumin. Let's actually go ahead and answer the first and most prominent use case scenario in which we should not be using albumin: when a patient has hypotension and a low serum albumin. Now, you might be asking why? Because mechanistically, sure, it makes sense. Now, while there are many scenarios in which things may make sense mechanistically or anatomically or physiologically, we always have to reference what does the literature indicate, because we always want to practice good evidence-based medicine. Now, in this case, while there is evidence that support that something like a low serum albumin is actually a good predictor for mortality, low serum albumin as a metric for volume resuscitation with albumin does not improve mortality. Now, this is a topic that is frequently revisited. Recently, the Icarus ED trial came out. I would recommend you head on over to Pulm CCM. They do a great breakdown of these things. But what they looked at in this trial was albumin use as a form of volume resuscitation in the setting of septic shock. Now, again, as you'll see with many studies, there are often positives, negatives, and neutrals. Now, in the Icarus trial, at 24 hours, there was no improvement in mean systolic blood pressure. However, there were improvements in things like vasopressor requirements or markers for organ dysfunction. Now, can those be directly attributed to the albumin itself relative to, say, crystalloid infusion? Difficult to say. But the ultimate question that we have to ask ourselves is, does this improve mortality? And unfortunately, in this case, just like many others, there is no quantifiable mortality benefit. Should we do it? Probably not. We can return to our earlier example of sepsis to apply some of these principles. We had talked about how the inflammatory cytokines that are circulating in your body lead to endothelial glycocalyx damage. That albumin that you put in, guess where it's going to go? It's going to go through the holes. So we've talked about two instances where albumin doesn't work. How about we talk about where it does work? After a large volume paracentesis. Now, in these settings, think about the types of patients that are typically getting a large volume paracentesis. Those are usually going to include people with severe liver dysfunction who already have a low serum albumin. In the setting of large volume paracentesis, you can develop something called paracentesis-related circulatory dysfunction. In these settings, you can give 25% albumin to help pull some of that fluid back into the intravascular space and offset systemic hypotension. This is a situation in which crystalloids are actually proven to be inferior to albumin. Another prominent and what I would probably argue as a more important and more prevalent use in the ICU is in the setting of hepatorenal syndrome. Now let's walk it back a little bit and review. In some of our other podcasts, we've actually talked about how some of that hepatic physiology works, especially when it becomes decompensated or altered, especially in the cases of something like cirrhosis. Just to review, cirrhosis leads to portal hypertension, and then you develop subsequent splanchnic vasodilation, which results in arterial underfilling and ultimately renal hypoperfusion states. In this setting, albumin, typically paired with some sort of vasoconstricting agent, whether that be an intravenous vasopressor or something like midodrine, can help to offset this effect and improve renal perfusion. Another good case use is in the setting of spontaneous bacterial peritonitis. Trial data does indicate that administration of albumin during the setting can help offset some of these issues, including the onset of hepatorenal syndrome when given in combination with guideline recommended medical therapies. Now let's take a moment and talk about the risks associated with albumin administration. In the clinical setting, everything we do carries a risk to the patient, which needs to be carefully weighed against the potential benefit. I bring this up because we often have a "what harm could it do" mentality, which isn't necessarily always wrong. Albumin is one of those that fall in the category of often being thought as benign but expensive. And it's not to say that cost isn't necessarily something that should be considered, because when you compare albumin to something like crystalloids, the cost can actually be like 10 to upwards of 50 times more. While our primary concern is that the patient survives and has the best possible functional outcome that they can, we also want to consider what their life and financial situation looks like after discharge. So risks include things like pulmonary edema, secondary to volume overload. You can also have hypersensitivity reactions. You have to remember that albumin is also considered a blood-derived product, so there are issues that come with that in and of itself. Another interesting one to consider is infection risk. Historically, that has been a proposed issue as the preparations were different than modern preparations. Modern albumin preparations are heat treated and are safe. As far as we're aware, there have been no infections related to albumin administration in the preceding decades. So it's pretty safe in that regard. There are also potential effects on coagulation as well as renal perfusion that have been reported in small studies. Since we brought it up earlier, I'm sure you're all wondering at this point, well, what is the evidence for intradialysis hypotension use of albumin? On this one, I'll jump right to the front of the line. The guidelines do not recommend routine use of albumin for intradialysis hypotension or IDH. Now, that being said, do they recommend not using it? No.
So that was a lie.
There are case uses for it. Albumin relative to crystalloids in this setting does have a more rapid correction of systemic blood pressure and can help quickly resolve, while it may be transient, hypotension related to dialysis. There are also case uses for profound hypoalbuminemia resulting in hypotension, as well as situations in which you're attempting to improve their blood pressure without potentially volume overloading them with high volumes of crystalloid. So let's recap and wrap this up. Good case use scenarios: large volume paracentesis, hepatorenal syndrome, spontaneous bacterial peritonitis. Now there are some reasonable case use scenarios, so we'll call that the middle ground. And one of these is that which we just mentioned: refractory hypotension secondary to dialysis. While it's not routinely recommended, it is a reasonable thing to use. Now, when we don't use it: sepsis resuscitation, routine hypotension for volume re-expansion, correcting for low albumin, situations like ARDS, or generic resuscitative efforts. So in the end, albumin isn't totally bullshit. But just like anything else, we need to make sure that we're being judicious when we use it and practice good evidence-based medicine. Thank you for tuning in. As always, we really appreciate the support. If you found this helpful, do us a favor, hit the like button, give us a follow, comment down below, let us know what you want to hear us talk about, and stay tuned for our full-length podcast episodes where we discuss these topics in depth. Thanks again for tuning into the Full Code Podcast series, Critical Minutes.